Hello, everybody. Welcome to today's webinar. I'm going to give it just 1 minute here for, I see the counter going up with attendees coming in. So I'm just going to give it 1 more minute and then we will get started. I see people are continuing to join, which is wonderful. I will go ahead and get started so that we can maximize the time we have together today. So I am so pleased to welcome you to today's webinar titled Financing Measurement-Based Care in Community Behavioral Health Settings. My name is Shoma Ghosh, and I am an Associate Vice President within the Behavioral Practice at WestApp, Behavioral Health Practice at WestApp. WestApp is an employee-owned corporation located in Rockville, Maryland. We do lots of federal contracting work across the Department of Health and Human Services, including with the Substance Abuse and Mental Health Services Administration, SAMHSA. I'm coming to you today from Appleton, Wisconsin. It is 33 degrees here, which is actually very pleasant for this time of year, but I don't want you to be too jealous because tomorrow morning they're saying it's going to be 5 degrees, and then Thursday and Friday I'm going to wake up and it'll be 0 degrees for real. Like if you check the weather, it's going to be 0, and that is Fahrenheit. So yeah, don't be too jealous. I am actually part of the leadership team for the SAMHSA Center for Financing Reform and Innovations contract, and that's where this webinar is coming out of. So we call ourselves CFRI, C-F-R-I for short, and it's a really neat contract, and hopefully some of you have gotten to see some of the webinars we've already completed as part of that contract, but we do all kinds of fun things like produce reports and issue briefs and journal manuscripts. And we cover really the most relevant financing issues that are facing the nation. Some of our recent reports include value-based payment on substance abuse, using value-based payment with substance use disorders, and Medicaid coverage state by state for medications to reverse opioid overdose, treating alcohol and opioid use disorders. And then also, I just wanted to mention that coming up in January, January 7th to be exact, we're going to have our next webinar, which is focused on behavioral health care access among lesbian, gay, and bisexual populations. The registration for that webinar isn't quite open yet, but it will be open later this week. And so check back on our CFRI website. I really encourage you to visit the CFRI website. The way to reach it is www.samhsa.gov/CFRI. And when you go to our website, you'll see all of the different reports and webinar recordings and slides that we've put together over the past few years. And hot off the presses today is the report that we're highlighting in today's webinar. And the report is titled the same as this webinar, Financing Measurement-Based Care in Community Behavioral Health Settings. For today's webinar, we had over 900 registered individuals, and so we're very excited. And I think if you look at the participants counter, you can see we're nearly at 300 and we're growing here. While we wait for other people to join, let me just cover a few housekeeping slides. Housekeeping items. So this webinar is being recorded. The recording along with the slides will be posted to that SAMHSA CFRI website. Anybody who registered for this webinar, even if they're not here today, will receive an email that will point them to the recordings and the slides and the report within about 10 days. You'll notice that with the exception of our speakers, every one of you is coming in on mute with your video recording off. And that's just to maintain kind of a high quality recording that we can then put on the website. I'd like to draw your attention to 2 items on your webinar console. One is the Q&A widget and one is the chat widget. I can already see that people are taking advantage of the chat widget, and I'm so happy for that, and continue to do that. It's your way of communicating with each other. The Q&A widget is going to be the primary way that you can ask questions of our speakers. So if you have any questions at any time, go ahead and type it into the Q&A widget. And we have people on the back end here who are reading those questions. And we will have time for a Q&A session at the end of this webinar to answer some of your questions. And other questions might be answered in real time as it goes. The Q&A widget is also what I want you to use if you're having any technical difficulties. So if you can't see, your slides are stuck, whatever, use the Q&A widget to ask our tech staff for help. They're monitoring that. So anytime during the webinar, you can use that. Let me tell you a little bit about today's webinar. We have a really great lineup. We're gonna have Dr. Peggy O'Brien give us an overview of the CFRI measurement-based care report, which, as I mentioned, is on the CFRI SAMHSA website, which will be followed by a panel discussion, and we'll have about 10 minutes that we've allocated at the end here to answer some of your questions that you put into the Q&A widget. To begin the webinar, I'd like to introduce one of my favorite people in the world that I have introduced on other CFRI webinars in the past. Dr. Ingvild Olsen is with us today. Dr. Olsen serves as the director for the Center for Substance Abuse Treatment. She has a long history of working with the addictions treatment field to expand access to care and enhance quality of care. So, and with that, I will turn this over to you, Ingvild.
Great. Thank you so much, Shoma. And it is so wonderful to see so many people, and the group is growing. So I'm just really excited to be here. I am here on behalf of myself, as well as my colleague, Dr. Anita Everett, who is my counterpart in the Center for Mental Health Services here at SAMHSA. Unfortunately, she's unable to be with us today. But I'm just really excited to be able to say a few words just ahead of this webinar on measurement-based care for behavioral health. As an addiction medicine specialist and a general internist, I've used some of the measurement-based care tools, like the PHQ-9, like GAD-7, like many of the other tools that some of you may all be familiar with, and I run into some of the same barriers that I think are highlighted in the report. And I'm just so excited that we're able to really be able to put this together and have Dr. Peggy O'Brien walk us through this. I also just wanted to really thank Shoma and the team at Westat and at CFRI for all the work on this and many other reports. Shoma mentioned some of the reports that SAMHSA has published or hosted kind of over the last few months. And if folks are also interested, there is one on financing peer recovery support or opportunities to enhance the substance use disorder peer workforce, financing peer crisis respites in the United States, best practices for data. And in addition to the CFRI SAMHSA website, you can also find more of these resources and more information on just the SAMHSA website as well. It's just one example of how SAMHSA really is committed to providing resources and support to help states and communities provide quality care to individuals with behavioral health conditions, both substance use disorders as well as mental health conditions. And for those of you who may be unfamiliar with the concept of measurement-based care for behavioral health care, just a really quick word about that. It is a clinical process that really uses standardized, valid, repeated measurements to track a client's process over time and their progress over time, and help inform mental health and substance use disorder treatment services. And really, at its best, it involves shared decision-making with clients. It's one of those tools that really allows us to make shared decision with the people that we serve as practitioners and providers. It is an evidence-based practice that really provides the structured approach to mental health and substance use disorder treatment that fosters personalized care and efficient resource allocation to really better support the client. And there is a growing body of evidence that shows that measurement-based care, or MBC, as we know it, is effective in improving quality of care and client outcomes. And there's been so much we talk a lot in many different areas around quality of care and around how to ensure quality of care. And this is one of those very practical tools and approaches that allows us to do that. This is also a practice that aligns with SAMHSA's mission to lead public health and service delivery efforts that really promote mental health, prevent substance misuse, and provide treatments and supports to foster recovery while ensuring equitable access and better outcomes. And we are absolutely committed to efforts to provide treatments and supports to foster recovery and ensure those better outcomes for all Americans. And we've been actively working to support the wider adoption of measurement-based care. A little over a year ago, so in June of 2023, SAMHSA, working closely with the American Psychiatric Association, the Association for Behavioral Health and Wellness, and the National Institute of Mental Health, convened approximately 50 experts to really explore the next steps to increase the use of MBC. And at that meeting, one of the major issues that was identified as really being a barrier to the wider implementation of measurement-based care was just the lack of knowledge around how to incentivize and reimburse for it across behavioral health providers and settings. And so in response to those findings, this is the report that we have been able to support the development of and the release of today, Financing Measurement-Based Care in Community Behavioral Health Settings. And in reading that report, I was just really reminded and struck of how not only in so many community-based settings, places like certified community behavioral health clinics or CCBHCs, where they really have an emphasis on outcomes and accountability, integrated care, and existing payment structures, that they're kind of an ideal environment for measurement-based care. I think the other piece that really struck me and highlighted for me is that there is a need to increase research focused on measurement-based care for substance use disorder service delivery and implementation. So in areas like opioid treatment programs and other specialty SUD treatment facilities. And it really is very important for the substance use field to continue to look for those opportunities to identify those practices and tools and research in that substance use services space that align then with measurement-based care, and then opportunities to embed those in our services. I think the other piece just I wanted to highlight is that in the future, we all wish we would have a crystal ball, but I do think that there is, because of the interest in measurement-based care and really trying to figure out how can we use this as that practical tool to help also with that progress in providing quality of care, that there may be other opportunities to use areas like augmented intelligence for recording elements and populating measurement-based care dashboards, for example. That could involve automating some elements of data collection and analysis, symptom tracking, use of predictive analytics. And so we really hope that this report and our panel discussion today will not only increase awareness about measurement-based care, but also help you all think about and help us think about how do we actually then open the door to sustainable financing and to some of those other research areas and opportunities that may be out there, not only today, but in the future. So I just want to thank you again all for your time, your interest in this topic. I just really also want to thank today's speakers and expert panelists for their participation, Dr. Peggy O'Brien for presenting the report findings, and also my colleague Angie Walker for overseeing this project as the SAMHSA task lead for this particular deliverable. And then finally, again, also really like to thank the WestStep team for all the work that they do on CFRI and really putting this webinar together. So I'm going to now hand things back to Shoma.
Yes, thank you so much, Dr. Olson. I want to encourage everybody to, again, go visit our website at www.samhsa.gov/CFRI. Next is going to be Peggy O'Brien, and she's going to provide some highlights of the report that's out today, where you can find it on that CFRI website. Dr. O'Brien is a social science analyst in the Office of Evaluation at SAMHSA, at the Center for Behavioral Health Statistics and Quality. And I have worked with Peggy for, I want to say 15 years, but I feel like we're dating ourselves. But and with that, Peggy, over to you for your presentation.
Thank you, Shoma, and thank you, Dr. Olson. So Dr. Olson did an excellent job of taking care of much of my first slide. She defined measurement-based care. I'm not going to repeat it. I do want to say that we are focused on behavioral health, and that encompasses the spectrum of both mental and substance use disorders, as well as other factors that may affect a person's mental well-being. And our focus on community behavioral health settings is inclusive of all types of outpatient settings in which behavioral health services are provided. So it may be a specialty behavioral health setting, or it may be a predominantly physical health setting, which offers behavioral health services. Next slide, please. So there's a rich literature on benefits associated with measurement-based care. Many of those benefits are summarized on this slide. The benefits include improved decision-making by providers based on use of standardized instruments, increasing client participation and engagement in treatment and care, including facilitation of client-centered treatment planning, and improved client monitoring and progress. Earlier detection of symptoms and symptom changes with associated potentially quicker reduction in symptoms, and most of all, empowered clients. Next slide, please. So one approach to use of measurement-based care that we emphasize in the report is its use in integrated care settings. Integrated care coordinates and provides joint delivery of behavioral and primary care, as well as other physical health care services, which may or may not be co-located. Behavioral health integration encompasses various levels of care coordination and collaboration, and identifies methods for integrating behavioral health services into primary and specialty physical health care settings and primary care into behavioral health settings. Depending on the strategy implemented, MBC may be a component, with one such strategy in primary care settings being the collaborative care model, an evidence-based team approach to care integration. Next slide, please. Despite documented benefits of measurement-based care, adoption remains slow, with one significant challenge being financing. The report released today explores some reimbursement options and identifies potential financing solutions for increasing use of measurement-based care across different community behavioral health care settings. In the spring of 2024, our contractor led discussions with an array of payers, policymakers, behavioral health financing experts, and providers. An environmental scan of published literature and reports also was conducted. There is not a lot of literature on financing of measurement-based care. Next slide, please. This slide focuses on value-based payment approaches that might be used to reimburse and thereby encourage use of MBC in behavioral health care. This is in contrast to fee-for-service payment, where each service is individually reimbursed. Value-based payment models have potential as they focus on the value of care rather than the volume of services when they determine payments to providers. For the sake of time, I will not go into detail, but the report discusses the 4 types of value-based payment that are noted here, which include pay for reporting, pay for performance, bundled or episodic payments, and capitation. Next slide, please. There are no MBC-specific CPT codes. However, the published report collects a number of billing codes that may be viable to obtain reimbursement for MBC. As shown on this slide, these include 4 general codes related to screening and assessment for adults or children, ranging from use of single standardized instruments to developmental screening to risk assessments. There are 2 codes identified that are specific to use of validated instruments for assessment or monitoring, coupled with care planning and coordination. And finally, there are 4 codes specific to the collaborative care model. Next slide, please. Study findings show minimal use of fee-for-service payment approach to reimbursement for measurement-based care and behavioral health. As I mentioned earlier, value-based payment arrangements do have potential to improve financing of MBC, but also are not commonly used in that context. Some organizations and providers, however, do view MBC as foundational for future value-based payment and for obtaining leverage in contract negotiations with payers. Thus, we find that the adoption of MBC in behavioral health services seems to be currently driven more by its clinical utility than by financial incentives. Our discussants identified some significant challenges of financing MBC for behavioral health services and highlighted a few potential strategies to overcome them. All of these are in the report, and I will summarize them. Next slide, please. Among the challenges identified were ones related to payer alignment. Specifically, the different payers and state Medicaid programs have varying policies and coverage criteria for MBC, and that lack of alignment increases burden and administrative complexity for providers. Among some potential solutions highlighted are developing reimbursement guidelines for MBC services, convening collaborative work groups between payers and providers, encouraging and testing MBC within existing federal programs, or implementing a federal or state MBC demonstration program. Next slide, please. A challenge related to direct billing was that the lack of MBC-specific CPT codes makes it more difficult for providers to accurately document and directly bill for MBC services. Potential solutions included rewarding providers who utilize MBC and making it easier to bill for services, requiring commercial payers to include MBC for behavioral health care in their contracts and provide support and incentives, incorporating and incentivizing the reporting of additional outcome-focused behavioral health quality measures, and encouraging and testing MBC within existing federal and state efforts, such as the CCBHC demonstration. Next slide, please. Our discussants also identified challenges related to IT infrastructure, including a lack of widespread use of robust IT infrastructure and integrated technology that can be useful for efficient data collection, analysis, and reporting in behavioral health settings. And the fact that many small behavioral health providers do not have the budget to develop or purchase IT infrastructure. Suggested solutions included providing upfront funding to support integration of MBC into practice and integrating MBC tools into telehealth platforms. Next slide, please. Finally, the report indicated challenges related to workforce and workflow, including the fact that adopting MBC requires workforce and workflow changes and thereby increases costs, with expenses coming from training staff on assessment tools, integrating MBC into treatment planning, documentation for billing purposes, and using IT platforms. Some potential solutions include providing technical assistance and training on how to integrate MBC into clinical workflow, utilizing existing workforce by task shifting and expanding staff roles, educating the behavioral health workforce on how MBC is crucial to providing evidence-based and client-centered care, and encouraging more accrediting organizations to adopt MBC standards. Next slide, please. So uptake of MBC in behavioral health care remains low. In trying to facilitate its use, it's important to ensure that these efforts to increase adoption maintain a client-centered focus and deliver care that meets the individual needs of each client. Financing also is needed to truly accelerate and sustain uptake of MBC in behavioral health services, in addition to a variety of other interrelated supports. Some key conclusions in this regard include simplification of billing with use of specific MBC CPT codes, increasing overall payments to address extra costs associated with MBC, providing upfront capital for IT infrastructure and providing technical assistance, encouraging MBC use in existing federal and state programs, task shifting available staff and ensuring that payment encompasses those staff, and increasing research on financing MBC use, especially for substance use treatment service delivery. And so that is the end of my report summary. We're going to move on to our panel discussion. So next slide, please. Okay, I'm going to continue moderating this section of the webinar, followed by a period of open Q&A led by Elian Rosenfeld. I'd like to welcome our two panelists who have graciously given us their time and expertise this afternoon. Shannon Hall is the Executive Director of the Community Behavioral Health Association of Maryland. Through the association, Shannon leads a provider network called Maryland Behavioral Health Solutions that spearheads innovative care approaches and value-based purchasing in Maryland. And Dr. Henry Chung is a clinical professor of psychiatry at the Albert Einstein College of Medicine and formerly Senior Medical Director for Behavioral Health Integration Strategy at Montefiore Care Management Organization. Dr. Chung is a leading consultant in national and regional initiatives focused on the implementation, policy, and financing of primary and behavioral health care. So I'm going to start. I will start with Henry. Henry, your work is largely dedicated to implementing and improving the integration of behavioral health care into primary care. Can you tell us a bit about the use of measurement-based care specifically in behavioral health integration?
Oh, great. And thanks so much, Peggy, for that introduction. Just a quick note, my internet seems to be going in and out. If you find that my audio is dropping, I'll come out of my AirPods and maybe that will help. So just someone let me know. So as it relates to integration, I've spent most of my psychiatric career working in primary care settings. And I will tell you that, as you know, most of measurement in behavioral health is actually coming out of integrated programs. When you look sort of across the country and you say, well, who is actually doing measurement of behavioral health care? And in what settings? Most of that data is coming out of primary care settings. And that's because integration itself, and that's integration of behavioral health into primary care settings, that's because integration itself, working in primary care, where measurement is very, very commonplace for a host of chronic illnesses, that this sort of culture of measurement is more easily adopted. Now, that's not to say, though, that all programs that do integration necessarily do measurement. We had the experience at Montefiore where we had both collaborative care models, which is a very specific model where measurement is one of the key pillars of that model, versus a standard, we call it co-location model, in which you put behavioral health practitioners into primary care. And we found at Montefiore that the co-location model did not prioritize measurement. So we had a natural experiment that we were able to do over the course of a year in looking at the specific outcomes of patients who had access to depression treatment in both co-located and facilities that did the collaborative care model. And what we found, which we published, is that the patients who received measurement in the context of the collaborative care model got better faster. And we mean over the course of a 10 to 12 week period, almost double the rate of people whose symptoms fell much more dramatically. And that's largely because, as you pointed out, Peggy, in your data, that when people measure something and they discuss it with their patient or client, and the client understands what the value of the measure is to the treatment, that when things are not going on track, you can actually make treatment adjustments much more quickly. That's really sort of the secret sauce, if you will, of the measure.
Mhm.
Now, I will also say, though, that some other key learnings. The administration of the measure makes a difference. We did another natural study, and that is we had people kind of giving the measure, particularly early screens, verbally to the clients. Now, I worked in the Bronx at Montefiore, lots of patients of color, and giving it verbally, we dampened the response rate compared to giving the measures the way they were designed, which largely are patient self-report. So being able to do it in a way where the patients themselves are responding either digitally or even paper pencil gives you a much more accurate representation of the actual symptomatology. So that's another thing we learned. And then one more thing I'll simply say is that aside from culture, which I'm going to let Shannon talk about because she's great at this, in terms of the culture change aspect amongst behavioral health clinicians, data capture is absolutely key. I mean, if you're going to respond to the measure, you obviously have to be able to track the measure. And that is not a simple thing. And so, you spend a lot of time in integrated programs figuring out how to track the measure and then how to retrieve the measure because you have to be able to track it and then retrieve it when the patient's in front of you, when you're ready to make that treatment adjustment. So lots of things going on here. I wanted to give you a flavor of kind of my own experience. Obviously, we can talk a lot more about this during the panel discussion, but I'll go ahead and stop there.
Okay, great. Thank you so much, Henry. I'm going to turn to Shannon now. Shannon, as the executive director of the leading advocacy organization for Maryland's community-based behavioral health providers, your work is focused on improving quality of behavioral health care and access to treatment. What are some of the biggest challenges that face your members in adopting and sustaining MBC, and how is your association supporting them?
Thank you, Peggy. Let me start with just explaining a little bit about our association's role with our members. We coordinated with a number of our members about 4 years ago, and the members identified and worked with a measurement-based care vendor that they all agreed to work with and implement the similar sort of core metrics at the same time. And it's grown and evolved over the last 4 years, so that we currently have roughly 30 clinics implementing, and about 18 of those have agreed to track the same core measures, PHQ-9, GAD-7, Therapeutic Alliance, Pediatric Symptom Inventory. And we're sharing that data in an aggregate setting and coming together once a month to learn. So that's really where we are. We've got about, I think, 25,000 active Medicaid patients in that aggregate measurement-based care that we're looking at every month. I would say there are 4 primary challenges that have faced our members in implementing this. 2 of them we've made really, really good progress on, and 2 of them we need a lot more work. The 2 that I think we have done some phenomenal work on is really around identifying and overcoming clinician resistance to understanding, like, why are you asking me to do this one additional thing, and is this going to be used against me? And what Henry was alluding to, we've also a number of our members, because we were working heavily with the child population, because we launched this during the pandemic, we're really concerned about the acuity of the youth mental health needs that they were seeing. And so we have folks tracking suicidality at scale. There were a lot of concerns among our members and among clinicians, as Henry was saying, around, putting up an analytics dashboard that says this person's high risk for suicide, just around the legal jeopardies around that, and working through that. And on both of these issues, that monthly learning community supported by our vendor GreenSpace that we're working with across this implementation just sat down and tackled these problems, right? There aren't silver bullets, but we worked through them. We were we don't have magic solutions, but we got everybody to a place that they're satisfied with, and I think have really done some phenomenal work over that 4-year period in improving providers' suicidality response. So those are the exciting things. The two areas where I think we have a lot more work to do is around this really critical issue of getting broader payer buy-in and alignment. And we are struggling to find really good outcome measures for the more serious mental illness diagnosis like schizophrenia and bipolar disorder. And the nice thing is, with having such a visibility and scale in this effort, we have providers testing different tools, and we're looking at those. So I'm optimistic that we'll come up with some viable solutions on it. But that's where we are right now, Peggy.
Thank you. Thank you so much, Shannon. I have some questions that actually I'm going to address to both of you. And I think the first one, I'm going to address it to Henry first. In your experience, what financing strategies seem to be most effective, if you can identify any, for measurement-based care implementation?
First of all, Peggy, I think you basically foreshadowed this in your slides, which I thought was just wonderful, particularly that sort of last slide or next to last slide that showed the cascade of potentials. So I like to always say that when you're trying to make a change in the practice environment, truthfully, I still believe there's a role for fee-for-service. And I point to the fact that, yes, of course, you get more quantity, not necessarily quality. But when you're trying to get providers to do something different, it is often helpful, particularly when you're trying to scale it, to use a fee-for-service approach. What's the proof in that? There's plenty of proof, but in behavioral health, I'll tell you what has been the biggest dramatic proof is the use of the code 96127, which you highlighted in the report. 96127 was essentially a screening using a validated instrument. And when health plans kind of got the word that depression screening and follow-up was going to be one of those quality measures that people are going to prioritize, especially in primary care, people started to use 96127. And that particular fee-for-service code has gotten a lot of adoption, and it gets paid for. It's variable depending on, line of business, commercial, Medicaid, whatever. And also there may be a limit on how many times of the year you can use that code. But I think it is sort of an entry step into getting more measurement done. Now, we don't measure for measurement's sake. We measure for an outcome. So what's the next natural progression? The next natural progression is either pay for performance or a bundled payment approach. I'm familiar with both. If you're going to do a pay for performance approach, to Shannon's point, you have to have some kind of benchmark. You have to be able to say in the field, we believe it is reasonable for people to get better within a particular period of time, and we would expect that X percentage of people might get better, and that's going to be a benchmark we're going to ask this organization to shoot for. And if you meet or exceed that benchmark, you're going to get paid extra. I think that's a very reasonable next step. In the field of quality improvement, that's often the way it goes. Fee for service, pay for performance, and then bundle payment. In New York State, we've been very fortunate, at least as it relates to the scaling of the collaborative care model, in that our state developed a special carve-out bundle for the collaborative care model. And guess what? Our state expects that when you get paid for that bundle payment monthly, you are expected to provide to our state regulatory authority your de-identified depression and anxiety outcomes. And that's a major motivator for people to figure out how to track, how to capture the data, and then how to report that data to their paying agency. So in my view, in the short term, if it were me, that's where I would kind of focus based on my experience.
Great, thank you. That was very thorough and very informative. Shannon, how about you? What financing strategies are you finding to be most effective in your implementation in your state?
Just say a me too to what Henry just said. You know, in Maryland, in the Medicaid program, they use CPT code that Henry referenced, 96127, and are reimbursing in primary care settings for the screening for anxiety and depression with PHQ-9 and GAD-7. But once you're positive and you're receiving behavioral health treatment, your behavioral health provider can't bill those same codes for the ongoing assessment and evaluation of patient response and seeing what is needed. So it's a shift in thinking that I think has to start happening and across the board. And I just love what Henry said about, you know, using that as the baseline and attaching a value-based payment strategy to that.
Thank you. Thank you. So Shannon, I think I'll start with you if that's okay on this one. What strategies can be implemented to ensure that payment models for MBC prioritize client outcomes and quality of care?
Yeah, in this one, I think it's really important that any strategies be really baselined in also looking at the risk that clients are coming in with. You know, we don't want to create incentives or a belief that everybody is going to get better right away, you know. So I think it's really critical to have a detailed look at this and to really start focusing on, you know, how long does it take to recovery? You know, what is reliable recovery looking like? And also understanding that there is and accepting that there's going to be a delta there and some folks who aren't. And I just think this gives us a great opportunity to hone in on those people who aren't responding to care in a really unique way and figure out what new strategies need to go in place. So I think there are a lot of real opportunities to drive care improvement.
So using the data not only for treatment and treatment planning, but also to see where real serious attention needs to be paid for people who are more outliers and accepting that there are outliers. Okay.
Yeah.
Yeah. Henry, how about you? What strategies would you recommend implementing to ensure that payment models prioritize outcomes and the quality of the care?
Oh, I just loved it. Everything Shannon said and want to dovetail on it. So she took a very patient centered oriented approach, which is absolutely critical. At a day-to-day level, that's what matters to patients and clinicians who care for them. But at a system level, I'm going to sort of take it 10,000 feet up. At a system level, you have to look at it from the lens of population health. And I'm going to put in a plug here for a report that the National Council and I worked on, a white paper, where we talked about how do we create the policy landscape for scaling measurement care in behavioral health. And in our view, we first need to prioritize the measures because patients who come in with behavioral health conditions based on a DSM-5, you know, it's a whole list. And one thing I think clinicians do worry about is that, well, if I have a patient that I'm treating with 4 comorbid conditions, bipolar disorder, PTSD, you know, and depression, and also ADHD, do I need to measure all 3 conditions? That's a real concern in terms of provider burnout. And also, what are you going to do with all that data? So from a population health lens, we believe that we ought to prioritize the prevalent conditions that occur. So depression, anxiety, substance use, and then include also the most common chronic medical conditions that also afflict our patient population, thinking about whole person. So that's the first thing I think we need to do is sort of say, let's agree as a field, which are the ones that we need to adopt from a population health lens. And then the second thing I would say is back to kind of my earlier point, which is that we need to sort of agree on what are the valid benchmarks, not for the purposes of saying one clinician is better or not. It's basically to set up an expectation for our field that, in fact, utilizing our evidence base, we can actually accomplish great things. And one of the things that bedevils our field is that we are not able to articulate in the same way that, say, other our colleagues in the medical field can say, well, look at what we've done in the field of diabetes and all the people we've improved in terms of diabetes control. I think we are still far away. Why? Because we're not doing enough measurement and we're not adopting those benchmarks. We should be able to say, right, of all the millions of people getting depression treatment, how many of them are getting better? A lot of them are, but we're not measuring it. We're not measuring it.
Thank you. Thank you both. I think I'll turn it back to Shannon for this one. Are there aspects of the report, the conclusions in the report that resonated with you in particular that you took away as being most significant or incomplete, perhaps?
No, all of the language around payer alignment, I think really, really resonates. It was exciting to see the report talking about CMMI's Making Care Primary approach. I think there are lots of opportunities for payers to look at this, and particularly, Maryland, like many other states, is facing a budget crisis, and for payers to be able to increase their confidence that that they're getting a result for the money that they have invested is more critical than ever. And we can look, over at David Clark in the United Kingdom. I mean, the work that they had done with a scaled measurement-based care implementation really helped translate to stronger investments on the payer side. We need to do that. And I think with our folks, combining the therapeutic alliance and the outcome measures, we're in really great position, I think, to help inform the dialogue with payers about when is it appropriate to cover telehealth, when is it not, and increase their confidence about coverage of core issues like that. So I think the report does a really good job highlighting the opportunities that exist in this framework.
Thank you. And I appreciate the focus on the therapeutic alliance. I think that that's a key part of measurement-based care. Henry, I'll turn it to you. Were there aspects of the report that you found most intriguing or disappointing? Be
Well,
honest.
first of all, let me just say I love the report. And
Okay.
like Shannon, I feel like the payer piece is absolutely critical. And if there was something I would have wanted to sort of get more out of the report, would have been a stronger direction about what payers should be doing. And I recognize that what was kind of the missing link from a payer lens, because I've run accountable care organizations, so I can think like a payer, is, well, what's the quality measure that you want me to anchor this to, right? Because if I'm going to be responsible for getting a 4-star, 5-star rating, and states say that there's a incentive for achieving that, and you're telling me that measurement in behavioral health is absolutely important, well, what am I going to anchor that to? So I think, again, we need to have better prioritization about what exactly those NCQA quality measures ought to be. Is it, for example, the number of measures that you get for depression and anxiety a year, and let's specify that, for good care, if you're going to see someone for 6 months, you should at least have 3 measures over that 6-month period of time as a minimum threshold, and that's a quality measure. Well, that would be a process measure, right? And then you could specify based on that how many people get better based on a benchmark. So I think if we were able to anchor that to a quality measure, fight for that quality measure, then payers would be able to say, okay, I can see how this is going to benefit, unfortunately, my bottom line. And whatever we can say, bottom line thinking still applies when it comes to the way health plans think. The other point I'd like to make about this is something that Shannon said earlier, which is the problem of what other measures would be more global in nature than the disease-specific ones. And I think that's absolutely critical. What's meaningful to patients? I think therapeutic alliance could be a wonderful one because it's transdiagnostic. It cuts across multiple conditions. So we need to invest in some research in that. The other one would be disability and function. So schizophrenia and bipolar. I think the World Health Organization Disability Adjustment Scale, which is only 5 questions and applies for both physical and mental health conditions, could be quite effective. And I know some organizations that are piloting that. And there are other kinds of measures. But I think, something like that, I think also could help us advance the field. Again, not a disease condition by disease condition measure, but let's, beyond the highly prevalent ones, let's start to think transdiagnostically.
Thank you, and I appreciate that. And you're thinking in the realm of recovery, among other things. So that's excellent. I am conscious of time, and I think that I probably should turn it over to Shoma or Elian. I believe that we have some time for questions and answers, and I think there's a lot that's in the widget. So
yeah, there's a couple of questions in there. Hi, everyone. My name is Eliane Rosenfeld. I'm a senior research associate at Westat, involved in the CFRI project, and was involved in this NBC report. I would love to hear from Shannon about the sharing of outcomes of the members of your behavioral health organization and how that impacts how the work continues.
Oh, I think it's absolutely vital to it. We're only looking at it at the aggregate level. With our vendor, the providers can, participating providers get it all broken down by patient and clinician. But we get together, once a month, we look at the aggregate. We just kind of talk about our goals and our performance. We sometimes, we come up with more questions. That's where we try to break things down, like telehealth versus in person, and a lot of different work that way. Sometimes we have broken it out by different provider, and you just see really, really dramatically different results. But you always also have to come back to, what's that starting baseline with the patient coming in? Because different providers have different business models, and somebody doing school mental health is going to have really different sort of outcome results than somebody, finding homeless individuals under bridges. So it's been the highlight of my career. It is, I think, so much in healthcare is about regulation and compliance and get paid. And this has been a conversation about what do we need to get folks better and to help, build the case that this is an important thing that payers need to invest in.
Thank you. You did touch on 2 other questions that some folks had, but this was around how MBC can be used for pediatric populations and then for other groups, like in correctional settings, and open it up to both of you.
Well, I'll let Henry go first.
No, Shannon, you lead because of your early emphasis on pediatrics.
Well, we're using the Therapeutic Alliance measures and then a transdiagnostic pediatric symptom inventory on the children that we're working with. And I'm sorry, Ellen, can you repeat the question beyond that?
Sure. There was also a question of, can it be used in correctional settings or other settings outside of integrated health or behavioral healthcare settings?
It seems to me like it's got a broad application, but I don't know, Henry, if you want to weigh in specifically on that as well.
Yeah, I mean, I think that there's very little research about measurement in behavioral health and correctional settings. So I don't want to go so far as to say that it would be effective. One of the things I always get concerned about, because clinicians raise it, is they say, what about concerns of secondary gain if there is secondary gain? Now, again, we typically have not seen that much in the published literature. But when you start to talk about certain settings like, incarceration, correctional, and others, there could be some other motivating factors because, again, these are not biological measures. These are measures that are largely driven by patient self-report. So that's one of the limitations. I do want to address, if I can, Elian, a question that came in from Lindsay in the chat, and it's a critical one, and I think Shannon can also address this. And this goes to the heart of what I've heard also. Lindsay asks, it sounds like potentially NBC will lead to providers turning people away due to severity and non-compliance. And we do hear this from providers because it feels like it's a provider profiling type of thing. And it may also feel like, oh gosh, this person's, way too ill, I don't want them on my caseload kind of thing. And if anything, the literature of measurement-based care is just the opposite. That in fact, what happens, and Shannon said this, is that people who actually have not gotten better, are tougher to treat, have a better differential outcome as a result of measurement. Now, why is that? And this is very interesting. This was done in a randomized study by Lambert, who is a psychologist at Brigham Young University. Very, very well-designed study. And they basically took people who were not responding to depression and anxiety care. And they randomized them to measurement versus not measurement, and then measurement plus patient feedback. And this was the key thing. Measurement where the therapist knew what the scores were and also what the patient knew what the score were. And guess who had the best outcome out of multiple arms? It was the arm where both the patient and therapist received the measure score and understood the relevance of it and how that might change their treatment. So what I would say in response to this concern is that, no, it's not about provider profiling. It is really more about how do we actually get people who ordinarily might not respond that easily to get a better response. That would be my view. It's a very excellent question by Lindsay.
Yeah. And 100%, I just couldn't agree more with that. This helps improve the patient care, not creating incentives otherwise.
So there was also a question about what can state Medicaid programs do, or what role could they play in promoting and financing MBC?
I'd say make, at a starting baseline, make the 96127 available on a fee-for-service basis, so that behavioral health providers can start implementing this, combined with some of, the reporting, that Henry had mentioned that New York is doing. And when you have a baseline, then you have an opportunity to lead at a broad level around quality improvement, setting goals, and everybody pulling the oars in the right way and creating some incentives and rewards around that. But you've got to start with the implementation.
Shannon, you're 100% correct on this. It still bugs me that state Medicaid programs that have, I think, a lot of influence over the Medicaid health plans, if they're a managed care state, continue to say that, PCPs can use this code, but behavioral health providers cannot use those codes. And this happens multiple times. And it's almost as if they kind of believe that there's value in this setting, but there's no value in this setting. And it makes absolutely no sense. You could make the argument that 96127 was really designed for screening. Well, in behavioral health, guess what? Like we do screen for all the conditions that someone may present with, known and unknown. And then secondly, because we have a bit more time with the clients in behavioral health, our instruments can be more thorough. So you can do, for example, a full PHQ-9 and a full GAD-7 as opposed to the PHQ-2 for screening and the GAD-2 for screening. And when you do the longer screens, you get more information. And when you get more information, you can actually address those areas that are not improving, right? So you get more data, if you will, to respond to from a treatment perspective. So yes, I think number one would be to have, Medicaid authorities, number one, prioritize, MBC with, health plans in general and find ways to incentivize measurement, at least at this 96127 level, and then consider ways of incentivizing providers who can accomplish, certain benchmarks, whether process or outcome, to get more measurement into the pipeline.
Thank you so much. That is all we have time for today, and I want to thank you all for an incredible panel discussion. We really appreciate it. Shoma, I'm going to turn it over to you.
Sure, and thank you, Peggy, Eliane, Ingvild, Shannon, Henry. I mean, I can't stop smiling. Your passion for this topic is obvious, and this was a fantastic webinar. I encourage everybody to go see our SAMHSA CFRI website again. That's samhsa.gov/CFRI. We will have the slides up there and the recording for this webinar up there within 10 days. The report is already up there. I encourage you to sign up for our next webinar on January 7th on behavioral health care access among lesbian, gay, bisexual populations. And on behalf of the SAMHSA and the whole CFRI team, thank you so much today for attending, and we wish you a very happy holiday season. Thank you.